All right, if you're a resident on the wards, you know this feeling all too well. Managing heart failure is a constant, tricky balancing act. So today, we're going to build a really practical guide to the 3 cornerstone therapies you are using every single day. We're talking diuretics, beta blockers, and ARNIs. Let's just dive right in.
So here's the game plan. First, we've got to understand the core problem, that vicious cycle in heart failure. Then, we'll break down our 3 main drug classes, loop diuretics, beta blockers, and ARNIs. After that, we'll get into the real nitty-gritty, the practical side of choosing and dosing these meds. And finally, we'll touch on what you do when those first-line options just aren't enough.
Okay, so first things first, let's talk about the core problem. I mean, why do we even need these super powerful medications? Well, it's because in heart failure, the body's own attempt to help a failing heart is actually what ends up driving it into the ground. It's this bizarre situation where a response that starts out as a fix quickly becomes the central problem we have to solve.
So here's what's actually happening. When that cardiac output drops, the body basically panics. It's like, whoa, red alert, I need to raise blood pressure and I need to do it now. So it unleashes its 2 big guns, the renin-angiotensin-aldosterone system, RAS, and the sympathetic nervous system. The goal is simple: squeeze the blood vessels and hold on to every drop of fluid to fix the pressure. But, and this is the key, this response is super short-sighted. It's what we call a maladaptive fix.
And this right here, this is that vicious cycle in action. See, it all starts with that initial drop in cardiac output. That's the trigger. From there, you get that whole neurohormonal cascade we just talked about. And the result? Well, you get vasoconstriction and the body holds on to salt and water. This jacks up the afterload. That's the pressure the already weak heart has to pump against. All that extra strain leads to harmful remodeling of the heart muscle, which, you guessed it, weakens the heart even more, lowering cardiac output further, and boom, the cycle just keeps feeding on itself. Our entire job, our whole goal with these medications, is to figure out how to break this destructive loop.
Okay, so the most obvious, immediate problem for so many of our patients is fluid overload, right? They're drowning in it. And our primary tool for that is, of course, the loop diuretic. But here's something that's really interesting, a key clinical pearl. Their most immediate benefit isn't actually making them pee.
So let's get down to the cellular level for a second. This is what's happening inside the kidney. Loop diuretics go to work in a very specific place, the thick ascending loop of Henle. And right there, they block this channel, the sodium-potassium 2-chloride cotransporter. Think of it like putting a roadblock up. By blocking it, they stop sodium from being reabsorbed. And as we all know, where sodium goes, water is sure to follow. That, my friends, is your classic diuretic effect.
But remember what I just said? The first effect isn't diuresis. So check this out. When you push IV furosemide, your patient often starts feeling better almost instantly, way before they start making more urine. And you're thinking, how's that possible? Well, here's why. Within about 5 minutes, furosemide triggers the release of prostaglandins and nitric oxide. And what does that do? It causes venodilation. It relaxes the veins. This rapidly reduces the preload on the heart. The actual diuretic effect, the natriuresis, that doesn't even kick in for another 25 to 30 minutes. That's a huge clinical pearl right there.
So when you're in an acute setting, what does this mean for you? It means you have to be aggressive. Seriously, the initial dose you pick isn't the most important thing. What really matters is how you react to the patient's response. The algorithm is super simple. Step 1, give a dose. Step 2, check the urine output in about an hour. Step 3, if you're not hitting your target, and we're talking over 100 to 150 mils per hour, you double the dose. No questions asked. And you just keep repeating that process until you find the dose that works. That is exactly how you empirically find a patient's threshold dose.
Now, it's really important to remember that not all loop diuretics are created equal. Let's compare the 2 workhorses we use all the time, furosemide and bumetanide. Furosemide's oral bioavailability, well, it's all over the place. We're talking 10 to 100%. That's why the IV to PO conversion is roughly 1 to 2. Bumetanide, on the other hand, is way more reliable, over 80%, so it's a clean 1-to-1 conversion. But here's the most crucial difference, their metabolism. Furosemide is cleared by the kidneys, so its half-life just skyrockets in renal failure. Bumetanide, cleared by the liver, so its half-life goes up in hepatic failure. This is the key to choosing the right drug for your patient. Let me put it simply. Bad kidneys, lean towards bumetanide. Bad liver, furosemide is probably your safer bet.
All right, let's shift gears to our next tool in the toolbox. You can think of it this way. While diuretics are busy managing the plumbing and the fluid,
Beta blockers are focused on managing the engine, the heart itself. Their job is to counteract that relentless, damaging sympathetic overdrive we talked about at the very beginning. You know, for a really long time, the idea of giving a beta blocker, a drug that weakens the heart's contraction, to a patient with a weak heart seemed completely backwards, right? It was totally counterintuitive. But we now know, without a doubt, they are absolutely essential for long-term survival. They do so much more than just slow the heart rate. I mean, this is one of the very few drug classes that is proven to reduce mortality. We're talking by about 35%. On top of that, they can actually reverse that harmful ventricular remodeling, improve the ejection fraction, and even restore a healthier heart rate variability. It's incredible stuff.
So this is the main pathway they shut down. Norepinephrine comes along and binds to these beta-1 receptors on the heart cells that kicks off a whole chemical cascade involving something called protein kinase A. The end result? Increased heart rate, increased contractility, and even a faster rate of relaxation. Now, in the short term, that might be helpful, but chronically, this is what absolutely drives the heart into the ground. Beta blockers basically slam on the brakes for this entire process.
And just to get a little deeper into the weeds, here's why this gets a bit more complex. While those beta-1 receptors are the main drivers of heart rate and contractility, the beta-2 receptors are kind of a mixed bag. See, depending on which signaling protein they hook up with, they can either be stimulatory or they can promote those harmful proliferative effects and that remodeling we want to stop. This subtle difference is a big part of the reason why we use very specific beta blockers in heart failure. You can't just use any old one.
Okay, on to our third major class, the angiotensin receptor neprilysin inhibitors, or as we all call them, ARNIs. Now, this is a much newer, and you could say smarter approach. It doesn't just block the bad stuff. It also actively tries to boost one of the body's own helpful protective systems.
So the key player here is an enzyme called neprilysin. Think of neprilysin as the bad guy in this particular story. See, your body produces its own defense mechanism against fluid overload and high blood pressure. These are called natriuretic peptides, and they are great. They cause vasodilation, they help you pee out sodium. The problem is, this neprilysin enzyme comes along and just breaks them down. So the idea seems simple, right? If we just inhibit neprilysin, we can keep those beneficial peptides around for longer.
But there's a huge catch, a paradox really. It turns out neprilysin isn't very picky. Yeah, it breaks down the good natriuretic peptides, but it also happens to break down the very harmful angiotensin II. So think about it. If you only block neprilysin, you get more of the good stuff, sure, but you also get a dangerous buildup of the bad stuff, and that's a total deal breaker. It would just make the heart failure worse.
And this is the truly elegant solution. An ARNI is a combination drug. It pairs that neprilysin inhibitor with an angiotensin receptor blocker, an ARB. So the neprilysin inhibitor boosts the good natriuretic peptides, while at the very same time, the ARB is there to block the receptor for the harmful angiotensin II. It's genius. You get all the benefits of boosting the good guys with absolutely none of the downside from that nasty RAS activation. It really is a brilliant pharmacological 1-2 punch.
Okay, so we've covered the what and the why behind these drugs. Now let's get really practical and move into the how. How do you make the right choices for your actual patient sitting in front of you?
So, let's circle back to our loop diuretics for a minute. How do you choose between furosemide and bumetanide on the fly? It really just comes down to the patient's other medical problems. If they have significant renal impairment, bumetanide is almost always going to be safer, because remember, furosemide's half-life gets prolonged. On the flip side, if they have major hepatic impairment, furosemide is the better choice. Oh, and one more thing, for patients with bad gut edema or really low albumin, where you're worried about oral absorption, bumetanide's reliability makes it the clear winner.
And please, you absolutely have to stay on top of your patient's labs. This is non-negotiable. The side effects of these drugs are super predictable, so you know exactly what to look for. With ARNIs, you're blocking ROS, right? So the big risks are going to be high potassium, hyperkalemia, and worsening renal function. With loop diuretics, it's the complete opposite. You're worried about low potassium, hypokalemia, along with wasting magnesium and calcium. And always remember, anytime you're making a big fluid shift, you can easily tip a patient into an acute kidney injury.
So, what happens when you've done everything right? Your patient is on the maximum tolerated doses of our big 3 cornerstone therapies, but they're still symptomatic. What do you do then? Well, that's when we look to our secondary agents for a little extra support.
Two of the main options here are digoxin and ivabradine, and they work in completely different ways. Digoxin is an old-school drug that works as a weak inotrope,
Put simply, it increases the force of the heart's contraction by messing with intracellular calcium. Ivabradine, on the other hand, is a pure heart rate-lowering agent. It has zero effect on contractility. It just slows down the SA node's firing rate by blocking the funny current. So you'd use them in totally different situations, depending on whether your patient needs more squeeze or just a slower rate.
And you know, it's funny. Even these really old drug classes are getting a second look. A pretty recent trial, the DIGIT-HF trial, looked at digoxin, which is a cousin of digoxin, and they found it could be a really valuable add-on for patients who just can't tolerate the max doses of our first-line therapies, maybe because of low blood pressure or kidney problems. It's just a great reminder that pretty much every tool in the toolbox has a potential role to play.
So let's wrap this up with a final thought I want you to take with you on your very next shift. Picture that really complex patient. You know the one I'm talking about? The one with the low EF, the soft blood pressure, and those borderline kidneys. How do you strategically combine and titrate these therapies? How do you layer them to maximize the benefit and minimize the harm? Which one do you start first? How do you know when to push the dose? The true art of managing heart failure lies in answering that exact question, in carefully balancing all the mechanisms we've just discussed to break that vicious cycle and give your patient the absolute best outcome possible.